I'd like to echo Mary's sentiments. I'm very grateful for people turning up in such goodly numbers on a very cold Friday evening. Just say a few words of thanks as well. I really am very grateful to colleagues in the Royal College of Physicians for hosting us this evening, in particular to Siobhan, Yvonne and Lynn, who've helped a lot in the background, and especially to Mary, who immediately jumped at the opportunity when it presented ourselves. Doug is over as part of another meeting that's going on with the HPV board, and I'm delighted to see some of the colleagues who were at the meeting, and they're also here. It's a group involving the World Health Organization, the Centres for Disease Control and other international experts specifically focused on HPV prevention and overcoming the challenges of HPV infection up to and including cancer. I'd also like to thank my own team in the Cancer Society and the colleagues I work with who've also helped and are helping this evening. Zita, Michael, Robert, Rachel, Hazel and Bella. A little bit of introduction for those that don't know just how esteemed a guest we have to speak this evening. Dr. Lowy is the Chief of the Laboratory of Cellular Oncology and Head of Signalling and Oncogenesis in the section in the world-renowned area of, in the world-renowned expertise. He has world-renowned expertise in tumour viruses and the molecular biology of cancer. He's an author and co-author of hundreds of research articles and key opinion pieces in the world of cancer. Dr. Lowy is Deputy Director of the US National Cancer Institute, having acted as Director for the last 2 years and having a long career in the organisation. And that organisation has given us many of the major advances in research and treatment since its inception in 1937. The NCI has been hugely supportive to research and cancer research and cancer support infrastructure in Ireland. Many of the clinicians here will have trained in NCI or NCI allied resources. Many of our researchers go over to the NCI, including for summer schools in cancer prevention and that. Dr. Lowy graduated with a primary medical degree from the New York School of Medicine and further trained in Stanford and Yale. And collaborating with Dr. John Schiller, he characterized the important oncoproteins and discovered and described a mechanism to construct a non-infectious HPV virus-like particle that had those virus proteins on the outside, very much like a normal virus. And this was key in developing a virus that we expect to give lifelong immunity to the HPV strains that it's targeted to. Along with obviously other investigators, this has been key to developing a functional and useful vaccine, which has now been given to over 270 million people across the world. Ian Fraser was mentioned by Mary, and also the late Dr. Zhang Zhu. That work has been recognised in many different fora, most recently with the award, the Lasker Clinical Medicine Research Award Prize. That wouldn't be a very well-known award on this side of the Atlantic, but it is literally like winning an Oscar. It is a very coveted award, and he shares that with Dr. Schiller. In the interest of time, there's actually a large list of other awards that Dr. Lowy has gotten, but I might just move on to those and not embarrass him any further. Roughly 300,000 women, between 250 and 300,000 women die annually, depending on the estimates of cervical cancer. And we know that several other cancers are caused by HPV, and other cancers on top of that are caused by other viruses. Roughly 1 in 40, 1 in 50 of all invasive cancers in the developed world are caused by HPV. So the virus is a big deal. Vaccination and prevention of that virus are a big deal in our efforts to overcome cancer. This year, about 44,000 new cases of cancer will be diagnosed over 2017. 21,000 of those will be invasive, and more than 400 people will be diagnosed with a cancer caused by HPV. The challenge is that we know that the numbers are going to increase unless we do something about that, and even as our population ages, our cancer numbers are going to grow. And we know that much of that burden is preventable. There was a report out in the last week showing that 42% of cancers in the United States and 45% of cancer deaths are preventable. And it was against this backdrop that we took the opportunity to ask Dr. Lowy to speak about cancer prevention and how his vision of the future, how we might impact that here in Ireland, just some of his thoughts on that. So I'm very grateful for him to agree to speak this evening. He's a very tight schedule turnaround here in Ireland, and I'll pass over to you now, Doug. Thank you very much.
For coming this evening. I appreciate that it's Friday night and also that it's World AIDS Day. I'm going to talk with you this evening about, I'm going to be focusing on cervical cancer screening and on HPV vaccination. But I'm going to be putting it in a larger context where I'm going to be talking about it in the context of what I call precision prevention and precision screening, in part because precision medicine and precision oncology really have gotten quite a bit of notoriety over the last few years. But the focus for precision medicine and personalized medicine has been almost exclusively placed on cancer treatment. And while cancer treatment is critically important, we shouldn't lose sight of the fact that there is also a lot of opportunity for precision medicine as applied to cancer prevention and screening. And so I'm using the two examples of cervical cancer screening and HPV vaccination as where I think things are going. In addition, I'm not going to be focused so much on what is happening today as on research that is being conducted and being more aspirational about where I think we might be in a few years. I should disclose that I will be talking about the vaccine, and I am an inventor of the technology, and it's been licensed to the two companies that make the vaccine. And I may discuss off-label uses of the vaccine protecting against HPV-positive oropharynx cancer and fewer vaccine doses. And I also am involved with other technology. So first, my definition of precision medicine. And in blue, it's really interventions to prevent, diagnose, or treat cancer based on a molecular and or mechanistic understanding of the causes, pathogenesis, and or pathology of the disease. Where the individual characteristics of the patient are sufficiently distinct, interventions can be concentrated on those who will benefit, sparing expense and side effects of those who will not. This definition makes it clear that population-wide interventions can be viewed, at least in principle, as a form of precision medicine. Precision oncology in prevention and screening, it's important to recognize that normal and premalignant tissues, the genetic and epigenetic changes generally are less complex than cancer. And so when there are premalignant changes, it's relevant to a higher proportion of lesions than after progression to invasive cancer. And in addition, resistance is less likely to develop against these early changes. So there are lots of reasons for thinking about trying to do something to reduce the risk of getting cancer, in addition to trying to improve the outcome for people who develop cancer. But it's important to recognize that precision-based approaches are not inherently better than empiric-based ones, but you must show that the precision-based approaches are clinically superior before they should replace empiric-based approaches. But because the precision-based approaches are based on new knowledge and new technology, a major theoretical advantage of precision-based approaches is that they may be more straightforward to refine and improve because they're based on a molecular understanding. And I'll show you that both in the terms of screening as well as intervention. Just one slide about the epidemiology of HPV-associated cancers. In the United States, about 30% of HPV-associated cancer occurs in men, particularly anal cancer and cancer of the oropharynx. and that means about 70% occur in women. So this is a cancer that involves both genders. And we have pap smear screening and now HPV-based screening, which have made dramatic changes in the incidence and mortality for cervical cancer, but we don't have approaches for these other in terms of screening. So the HPV vaccine actually is providing a potential benefit here that it is duplicating to some degree what we get from screening, but obviously preventing the development of the infection can be far better for people rather than getting the infection and having it needing to be treated. So what happens is that you go in a series of steps basically to from normal uninfected to getting infected, as shown here with this green line. Then you get pre-cancer and finally progression to invasive cancer. Most people who develop infection, the infection is self-limited and their risk of cancer then goes away. But a subset of women are going to have persistent infection, and they are then at risk of developing pre-cancer. And then again, pre-cancer usually is either stable or progresses or may occasionally regress. But then a subset of the persistently infected women with dysplasia may go on and develop invasive cervical cancer. So we have two opportunities to try to abrogate the cancer process. One is with primary prevention with the vaccine, as shown in green, and the other is with secondary prevention with screening. So I want to thank my NCI colleagues, Mark Schiffman and Nico Van Benson, for helping to provide some slides for this part of the presentation. But my feeling is that we often aren't clear about the purpose of cancer screening. The purpose is to reduce morbidity and mortality from cancer. It's not to identify cancer. It's not to identify pre-cancer. That is a means to an end. And the approach is to find and treat cervical pre-cancer or very early cancer. And one of the reasons why the pap smear and other kinds of screening that we do in the industrialized world work so well is that we're identifying pre-cancer, and it's much easier to treat pre-cancer than it is to treat invasive cancer. On the other hand, we have to avoid overtreatment of benign disease. So what I think we're seeing is a revolution in the approach to cervical cancer screening, because cytology-based screening has been based on pattern recognition. And obviously that's been highly successful, but it's expensive, it requires specialized expertise in cytology, and there are many false negative and some false positive results. HPV screening is etiology-based. It's more sensitive, it has higher positive and negative predictive value, and it's more readily exportable to low resource settings. Let me show you the problem in 2 slides. Cervical cancer, squamous cell cancer incidence has gone down substantially in the United States and in most other countries in the in the industrialized world as a result of pap smear screening. But adenocarcinoma incidence has not gone down. But when you look at randomized controlled trials, and this was 4 different studies that were pooled together from Europe, and then randomizing between following with cytology in red versus following with HPV-based screening in blue, there's substantially more cases of invasive cervical cancer after randomization that develop in the cytological screening patients compared with the HPV screening patients. But when you look at the type of cancers that are prevented, there's a minor decrease in squamous cell carcinoma that actually the 95% confidence intervals overlap. But where there's a tremendous difference is in adenocarcinoma. There are 3 cases of adenocarcinoma in the women screened by cytology compared with just 1 case of adenocarcinoma in the patients who were screened with HPV testing. So this is an example of how using HPV testing you actually can provide an advantage to women. Now, there are many different HPV types that cause cervical cancer, but HPV-16 is the most important of those types because it's responsible for about half the cases. And for the non-cervical cancers, it's responsible for about 90% of them. And my colleagues, Mark Schiffman and Nico Van Vensen, are doing studies in Northern California with Kaiser Permanente. And the next 2 slides are unpublished data from their studies. And what I want you to see is that progression to high-grade dysplasia, when women have 1 HPV test over the next few years, they're continuing to be followed, but the HPV-16 is really an outlier in being much more likely to progress to high-grade dysplasia compared with the other types. And as shown in the next slide, it's not because persistence is more common in HPV-16, because clearance, you can't distinguish really HPV-16 very much between that and the other HPV types. So HPV-16 is inherently more oncogenic. We can discuss potential reasons why later. But importantly, if you're persistently infected with 16, it's really a more serious problem. So we're trying to move to quantitative risk-based strategies for cervical cancer screening. And a problem is that HPV-based testing is too sensitive. Many HPV-positive women do not have moderate cervical dysplasia or worse, and they do not need to be treated. Most patients who are infected are categorized as being negative for intraepithelial lesion or malignancy, which basically means they're cytologically or histologically negative. And so the solution has to be some kind of ancillary testing. Right now, that is cytology, but I think as we go forward, based on improved understanding of the biology of the infection and improved technology for developing biomarkers that are associated with high-grade dysplasia, that we will be able to substitute with cytology for more easily quantitated other kinds of ancillary markers. And these are some of the markers that are being considered at the moment. And I'm going to show you some data from Mark and Nico's research using P16 and Ki67 by an automated process. P16 is upregulated in almost all HPV infections that are clinically important. It tends to be downregulated in many cancers. What happens is that the E7 oncoprotein, it essentially interferes with the activity of the RB tumor suppressor protein, which leads to the upregulation of P16, and Ki67 is an index of proliferation. So one of the key points is whether women should be referred to colposcopy. And if they're HPV positive by itself, that is, you can't be referring everybody because you would be referring so many people because there are so many people with HPV infection who don't require colposcopic examination. So using these two, the so-called dual stain, the Ki67 and the P16, if this is the threshold of risk that requires colposcopy, you can see this for the HPV positive women, all comers, but even more important, for the women who are cytologically normal, you don't need to, if they're negative for the dual stain, they can be referred back for regular follow-up, not as frequent, and don't need to be seen for colposcopy. And what Mark and Nico are trying to do is essentially be able to feed this information into a computer so that the clinician is going to be told, based on the risk profile of the patient, this is how she should be, managed. Let me show you what the current accepted algorithm is for screening management in the United States. And all I'm trying to show you here is it's complicated. And so the goal is, instead of needing to, every clinician needing to follow this complex outline, instead for the computer to feed in the information of the specific HPV type and other kinds of risk factors for the individual woman, and then come out with the recommendation. A potential advantage of this is that as we understand more about risk, we can change things inside by putting in more information so that our recommendations become progressively more and more rigorous. In addition, if there are different resources, you can essentially change the algorithm of how a patient should be managed. In a place such as the United States, where we can follow a lot of patients, we can triage them for follow-up, etc., or we can then have a lot of patients in that category. In a low resource setting, what you could do is have relatively few patients in that category, and most patients, they either would be treated or they would essentially go back to some kind of regular screening program. So I just want to remind you, this is aspirational. It is not yet ready for prime time, but research is being done to try to provide evidence that this approach can be effective. So before we leave the screening area, I just want to show you what's the profile of what's happening with mortality rates in the United States. I generally pay more attention to mortality rates than to incidence rates when they are available, because it's very difficult for different processes to modify mortality rates, much easier for interventions to change incidence rates. For example, when mammography screening became very popular, the incidence of breast cancer went up. When PSA screening became popular, the incidence of prostate cancer went up. But so that's why I tend to focus on mortality rates. You can see here in the United States, we are not doing well when it comes to liver cancer. And in the United States, a lot of that increase is attributable to a hepatitis C virus infection. And so one of the things that the NCI is supporting research on is to try to develop implementation and dissemination in the United States so that we can successfully treat the millions of patients who are still infected with HCV and actually find them and treat them effectively to decrease their risk of developing cirrhosis, liver failure, and liver cancer. We're also, obesity has become an important issue, and so we need to do a lot more research on understanding the relationship of obesity, inflammation, and the development of cancer, and how best to intervene in those areas. And I just want to also point out that colorectal cancer is one area where we've had substantial decreases, but we still have a long way to go in terms of screening. Some populations are well screened, but many populations are very underserved in the United States. And I know that you all have initiated colorectal screening, and I think it's a terrific way with enormous potential for saving lives, but it is complicated. I'm not going to talk about liquid biopsies. They do have long-term potential for screening, but instead I think that we would be better off to focus on fluids and for how to do various kinds of screening, to develop new kinds of screening. And in the United States, it seems to me that bladder cancer is one area where we know the molecular abnormalities that are present in bladder cancer, and it should be relatively straightforward to develop effective, that is clinically effective screening tests for high-risk populations that can do a better job and be much less invasive than cystoscopy, et cetera. So I now turn to vaccination, and again, I want you to think about this more in terms of precision medicine than specifically about the vaccine in general. And as Rob mentioned, John Schiller has been my partner in crime for a long time, and we have wonderful people that we work with. And I just want to point out that Reinhard Kernbauer, who did most of the research in our lab, developing the technology, is actually a dermatologist at the University of Vienna. So oncogenic microbial agents are molecular targets, and I want to make sure that people understand that they're just as much molecular targets as the EGF receptor, BRAF, et cetera. But they have theoretical advantages over cell-encoded targets because they're foreign genes and foreign proteins. It's easier to develop specific interventions against them than against cell-encoded genes and proteins, and serious side effects are less likely to develop. So HPV contains viral oncogenes, and so this essentially made it likely that you needed a subunit vaccine that lacked the oncogenes. And HPV encodes two proteins that can induce neutralizing antibodies: the major capsid protein, L1, and the minor capsid protein, L2. L1 contains the most immunogenic neutralization epitopes, and importantly, they're conformationally dependent, which means you need the structure of the virus particle for them to induce the neutralizing antibodies, which are the mainstay of most preventive vaccines. And our hypothesis was that L1 would self-assemble to make empty particles with the correct conformation and induce high levels of neutralizing antibodies. We essentially did this with recombinant baculovirus in insect cells expressing L1, and it indeed induced high titers of neutralizing antibodies. And what I'm going to talk with you about is that we didn't realize how immunogenic the vaccine was going to be and how protective it was going to be. And a large part of the research now is basically asking, how low can you go? And we've already seen going from 3 doses to 2 doses for young adolescents, and we are testing the possibility of 1 dose. I'll just point out that we did these studies initially with the bovine papillomavirus, a cow virus, not because we were interested in the public health problem of warts in cows, but because we had the necessary reagents. We had infectious virus, a neutralization assay, and so we were able to ascertain quickly whether what we had might be useful as a vaccine. We then went to HPV-16, the most important type, and it turned out that the HPV-16 that virtually everyone in the world was using was a mutant. And what we found was it didn't self-assemble well. It self-assembled about 1,000 times less well than the BPV. And so we asked colleagues, because the L1 from HPV-16 had been isolated by Harold Zerhausen, who got the Nobel Prize for identifying these HPVs. But it was isolated from a cancer. and the mutation had almost certainly arisen in the cancer. So we got HPV-16 from non-progressed lesions. Turned out that they're L1 encoded wild type. There was a point mutation in one amino acid in the HPV-16 that virtually everyone in the world was using because Dr. Zerhausen was so generous in giving that reagent to people. But then the self-assembly was just like BPV. And when we subsequently developed the neutralization assay, it turned out that the reference strain with the mutant, although it induced antibodies, they weren't neutralizing, whereas with the wild type, they were highly neutralizing. So the first generation vaccines were the bivalent vaccine made by GlaxoSmithKline called Cervarix, and Gardasil is the quadrivalent vaccine. Cervarix is more immunogenic, and it has more cross-neutralizing activity. So in addition to targeting 16 and 18, for example, in Scotland, there's been a tremendous decrease in 3 other HPV types that are closely related because they have a proprietary adjuvant. The Merck vaccine uses a more standard adjuvant called alum, but it, in addition, focuses on genital warts, and so there's been a dramatic decrease of genital warts in the countries that have used Cervarix, but it's less immunogenic than Cervarix, so there's not as much cross-neutralization, and the protection is basically limited to these 4 HPV types. And initially, it was 3 doses over 6 months, but there was tremendous skepticism appropriately about whether the vaccine was going to work because the track record of vaccines against sexually transmitted local infections had been 0. For example, herpes simplex type 2 vaccines had been tried. They worked in animals, they didn't work when they were clinically tried in people. In this situation, the animal studies were predictive of what happened in people. There have been a lot of safety studies, and let me just say that the side effects of the vaccine are similar to that of other widely used vaccines. The goals of vaccination really are twofold. One, to directly reduce the risk of infection and disease in the vaccinees. But the second one, which is just as important, is to indirectly reduce risk by reducing the prevalence of the vaccine types in the general population or developing herd immunity. And I'm going to really focus on herd immunity in the next couple of slides. Australia, because of the importance of Ian Fraser, was a high adopter country for HPV vaccination, and it was Gardasil. Okay, so you can use as your endpoint the prevention of genital warts in men to look at herd immunity. And so what happened in Australia, this vertical line is when they started when they started the vaccine program in 2007. And you see heterosexual men over the next couple of years, their incidence of genital warts plummeted. Heterosexual men who were over 30, who presumably were not having sex with vaccinated young women on a population-wide basis, they had no significant change. And the men who were 21 to 30 were intermediate, but statistically significant in terms of their decrease. And then earlier this year, the prevalence in men was looked at. In red is HPV 6 and 11, and it goes down rapidly after the initiation of female vaccination. I just want to remind you, the men were not vaccinated. It's only the women who were vaccinated. They didn't start vaccinating males until this point. And then HPV 16 and 18 are this green line. Takes a little longer, but they go down. But there are many other HPV types that are infected, and so those types, there was no change. Remember, there's very little cross protection with Gardasil. So the exposure rate was very similar over this time. and the decrease is specific to the 4 HPV vaccine types. In the United States, we have had low uptake of the vaccine. This blue line shows what happens in girls 13 to 17 years of age since the vaccine was introduced, and the the percentage of girls goes up of 1 or 2% course of vaccination. Boys, it was only had a strong recommendation in 2011, and it just keeps on going up. So I would say that the vaccination program in boys has been really quite successful, and I'm expecting by the end of next year that the percentage of boys being vaccinated will be very similar to that of girls who have been vaccinated. The high efficacy of the vaccine, we think, is attributable to 3 things. But I want to point out that the vaccine confers sterilizing immunity in most vaccinees. They just never get infected. They get exposed, but they don't get infected. Most vaccines, when people are exposed, there's low-level infection, and essentially you prevent the disease because of a decrease in the effective infection of the inoculum, and then further replication. We think that the sterilizing immunity that occurs in most women is because of the repetitive structure of the virus-like particle, that it's very immunogenic. That's what the immune system has been selected for to respond to. The tissue-associated neutralizing antibodies are exudated at potential sites of infection. What this means is that the level of exudated antibodies are high, similar to those levels in the serum, not the lower levels of the non-disrupted genital tract, especially women who are ovulating or taking oral contraceptives. The level of antibodies that they have in their genital tract is substantially lower than the level in the serum. And then HPV is highly susceptible to neutralizing antibodies. One slide about Gardasil 9, the 2nd generation vaccine. And again, this is using precision medicine to develop a 2nd generation vaccine that improves on the 1st generation. So Gardasil that is the quadrivalent vaccine, protects against about 70%, but Gardasil 9 adds the next 5 most oncogenic types in terms of their frequency of causing cervical cancer. And these 5, the protection of the comparison was done of Gardasil versus Gardasil 9 in the phase 3 trials, and there were 27 cases of cervical dysplasia among the Gardasil patients, whereas the Gardasil 9 patients, there was just 1 case. So it's well over 90% protection against the new HPV types. There still are some types that are not going to be protected by Gardasil 9, but it protects against most. The last topic is I want to talk about whether a single vaccine dose might confer years of protection. We have already gone to 2 doses for young adolescents based on their higher antibody responses in young adolescents compared to the women who were in the clinical trials, who were essentially in the 16 to 23-year-old range when they were immunized. But the NCI did a study of the HPV-2, or the bivalent vaccine, Cervarix, and we found, to our surprise, that the women who only got 1 or 2 doses actually were as protected against HPV 16 and 18 infection, and actually had as much cross protection as the women who got all 3 doses. Let me just show you. These are the women in the trial who got the control, who were in the controls. They actually got hepatitis A virus vaccine. And you can see when you look in the green, these are the HPV types that are not the types that are protected. Okay, in blue is HPV 16 and 18, and you can see that there's dramatic decrease compared to the control groups. But the one dose, the reason the blue isn't there is that there were no cases of infection with HPV 16 and 18. And the red shows the cross protection with these 3 HPV types. And you can appreciate that the cross protection with 1 dose is very similar to the cross protection with 3 doses. I will note, of course, that the 95% confidence intervals are greater because there are fewer numbers of patients here than there are here. This is not sufficient to change standard of care, but we think that the results are very interesting, especially when seen in the context of the women who got only 1 dose actually had stable serum antibody levels for the last 7 years. And that's shown here. These antibody levels are not as high as the women who got 3 doses, but they seem to be protective, and they're substantially higher than the antibody levels that we see after natural infection. So again, this is post hoc analysis, not enough to change standard of care, but we think that it provides a strong rationale for doing a randomized controlled trial. And so this trial, which is also going on in Costa Rica, is a 4-arm non-inferiority trial in 12 to 16-year-old girls. And we're comparing protection from 1 and 2 doses of Cervarix and 1 and 2 doses of Gardasil 9. It's unethical to have a placebo arm, so we're going to be measuring HPV prevalence in young women in the same area who are just older than the girls who are getting this. Both vaccines have been approved in Costa Rica, but they do not have a national vaccine program for HPV. The main hypothesis is that protection induced by 1 dose will not be inferior for 2 doses for at least 1 of the 2 vaccines. The second hypothesis is protection will be similar for 1 dose of either vaccine, and that will be evaluating the possible role of the adjuvant. As I mentioned, the adjuvants are different between Merck and GSK. And I am pleased to tell you that the first girls were vaccinated on Wednesday afternoon, so we only have 19,000 more to do. But anyway, it's a big trial. It is being partially supported by the Gates Foundation, but we think that it really could change the standard of care if our hypothesis is correct. But we do research to find out whether this will be adequate. So my last 2 slides before we get to the summary is first an anecdote. In the United States, the HeLa cells are very well known, and they're derived from Henrietta Lacks. And Rebecca Skloot wrote a terrific book that won the Pulitzer Prize about her story. And Oprah Winfrey starred in a TV movie earlier this year. But the reason I'm talking about it here is because she had HPV 18, cervical adenocarcinoma, which was not detected by cytology. But today, her cancer should be preventable by HPV vaccination or by HPV-based screening. In countries that don't yet have implementation of cervical cancer screening and vaccination, Xavier Bosch and his colleagues a couple of years ago proposed HPV Faster, which has been modified by Mark Schiffman from NCI to propose doing broad vaccination of just 1 dose for women up to age, say, 30 or something like that, while at the same time doing screening. And this would be starting in women who were, let's say, age 30. And by doing it this way, you would, in principle, be able to have an impact on cervical cancer long before you would have an impact from vaccination itself. Because if you're just relying on vaccination, it's going to take a couple of decades before you see an impact. Whereas here, you should be able to see an impact on mortality rates in less than 10 years. So let me summarize. Precision medicine can lead to rational interventions for prevention, screening, and treatment that may be more effective than purely empiric interventions. Basic research led to identification of HPV as the cause of several cancers and to development of HPV-based screening and the HPV vaccine. Second-generation HPV-based screening and second-generation HPV vaccines can achieve an even greater reduction in HPV-associated disease. And this last part is aspirational still. Control of HPV-associated cancer as a worldwide public health problem may soon be feasible. So thank you all for the invitation. Thank you for coming. I'm really looking forward to your comments and questions. Cancer prevention offers many opportunities to reduce the risk of developing cancer. And cancer prevention really has to do with vaccination, for example, hepatitis B, human papillomavirus, but also a healthy lifestyle, no tobacco, which causes not only cancer, but lots of other serious disease and clearly shortens one's life expectancy. Obesity, the same sort of situation. Cancer, as well as other diseases, shorten life expectancy. And part of a healthy lifestyle is exercise, which again can improve your risk for developing cancer as well as other disease.